Hi, everyone. Welcome to the afternoon session, and thanks for making it this far. My name again is Vijay Raja. I'm an interventional cardiologist. I do peripheral intervention, structural intervention. We're going to be talking today about a new technology. Before I go any further, I want to just kind of say that this is my favorite time of the year every year. I think we missed this last year a lot. This gets to, as you guys are meeting several of our new colleagues, this gets to showcase our new people. We get to meet them as well. And welcome to the family of the Arkansas Heart Hospital. So this was a very exciting part of the year, and it's been a tough 18 months, and it's been nice to have everybody back in the room again and do this. So thanks for being here. So we're going to be talking about pulmonary embolism and DVT and a new treatment option involving thrombectomy. So typically, anticoagulation is a staple of therapy, and we'll get into that in just a second. There's been thrombolysis, which is breaking up clot, and now with the idea of thrombectomy alone. So go over a brief outline of what we're going to talk about: incidence, risk factors, why do we care, standard therapy, so the general indications, the new options, a couple case examples. I have a case actually right after this to go do, and then some review and questions. So pulmonary embolism and deep vein thrombosis exists along the spectrum of pulmonary venous thromboembolic disease. So this occurs in about 65 to 110,000 per 100,000 admissions, about 5 to 10% mortality, which is probably the biggest thing that I care about in the hospital. This involves a triad of risk factors: the stasis of blood flow, vascular endothelial damage, which you've seen through great outlines of injury, and hypercoagulability. So this is pretty often, we're seeing that now with COVID and the risk of blood clots and a variety of different factors. So the standard guidelines include anticoagulation. So this is old data, but this is still evolving, and my wife, as an oncologist, will say that this is old news, but as I presented this to her to practice, but I said, well, this is the most recent stuff I can give right now. So it requires at least 3 months over no treatment of anticoagulation. Without malignancy, they do prefer the novel oral anticoagulants over vitamin K antagonists. Obviously, that's a cost is the biggest risk issue. With malignancy, they do lean towards low molecular weight heparin over the novel oral anticoagulants or vitamin K antagonists. She'll say that now, most of the time, they are leaning towards the DOACs. Excuse me. Where's the pointer? Yeah, they're leaning towards the DOACs. I think that majority of cases, we are trying to do this if they're still in the process of figuring out what malignancy, bridging, and staying on that course. Or if they fail these agents, that's usually, we know that they're getting adequate anticoagulation. There's currently no indication for IVC filter if you can put them on an anticoagulation. We see numerous cases where we have patients that have had long-term filters, and we're seeing more medical legal issues with these things. Obviously, it is indicated for the short term, but we have to think about and keep those patients in mind when we want to remove those filters and not have them long-term. There's no direct indication for catheter-based thrombolysis or thrombectomy over anticoagulation, but there are some few exceptions, and we're going to talk about those right now. So the new options, there's a device called ECOS, and basically it is indicated for either submassive or massive PE. This requires, a lot of times you'll see on the CT scan, they will say that there's a high thrombus burden, there's RV strain, but the majority of criteria is met by echo, and the echo guidance showing an RV to LV ratio of greater than 1. These patients have a high risk for post-PE syndrome, a high likelihood that they could develop long-term pulmonary hypertension. New York heart failure classifications of class 3 or greater, where they're limited with their functional capacity and their ability to do regular activity. The other cases are for iliofemoral DVT, so things from the belly button to the mid-thigh. These cases, have a high risk for post-thrombotic syndrome. They have a chance for chronic venous stasis, those ulcers that you see, chronic pain, and I think that the more aggressive we are with those cases versus over standard catheter or standard anticoagulation is preferred. The ECOS thrombolysis catheter is a actual catheter directed into the location. It is a ultrasound-mediated thrombolysis. We're infusing TPA into the location. With that lytic therapy, we have absolute contraindications. Obviously, if you're actively bleeding, you've had a recent stroke or neurosurgery, if you have recent major other non-cardiac surgeries or organ biopsy, intracranial tumors or spinal tumors, or even current GI bleeds. So these things are not that simple. You can turn it on and off, but the risk of massive bleeding in those situations is contraindicated. So the new technology has been available. So these are called catheter-directed thrombectomy. They have the same indications for both PE and DVT. So if you have a very large thrombus burden as far as from pulmonary embolism or an iliofemoral DVT, there's no indication for thrombolytics, and so these are directly sucked out as far as the clots. They involve two major systems right currently, penumbra and the Inari, FlowTriever and ClotTriever. These do require some tolerance for contrast angiography, so we have to use some radiographic dye, and so that their kidney function is an important factor in this process. So these are two case examples. The first one is a young woman came in from an outside hospital, had complaints of about 4 days of progressive shortness of breath, was diagnosed with COVID at the outside institution, was on about 6 liters of oxygen, blood pressure was running in somewhere between hundreds, 90s systolic. What you're seeing here on the left-hand part of the screen is the left pulmonary artery, and this is the right pulmonary artery. So think about it as though you were seeing branches on a tree. So normally you should be seeing nice, clear architecture, just like you'd see leaves on a tree. And so the smaller branches should be splayed out. When you take these catheters and you can measure the pressure inside the pulmonary artery, you'll notice that the mean pressure that's listed on the screen here is about 40 millimeters of mercury, which is moderate to severe pulmonary hypertension at baseline. So this woman is in distress. If we do standard therapy on this basis, she would not do well long-term based on conventional trials. The reason that she was a candidate for catheter-directed thrombectomy was that she was also noted to have a pericardial effusion on the chest X-ray, on the CT, as well as some kind of non-specific effusions in her peritoneum, which we'll get more into later, but basically was concerning for continuous bleeding with no recent surgery. So we thought the worry of putting catheter-directed thrombolysis would be more traumatic or more dangerous in this patient. So what we've done is the device itself for the Inari is we use a very large catheter inserted in from the right femoral vein brought back into the pulmonary architecture and aspirated. And what you can now see is very clearly the nice architectural tree for her pulmonary arteries, both inferior and superiorly, and the same thing for the right side. This is actually the coolest picture. This is what we removed. So this patient went from 6 liters of oxygen, blood pressure tenuous in the cath lab. We're ready for, these cases tend to be a little bit where you're ready to code with an idea that this is something that this person may need ACLS protocol in these procedures, but weaned off to 2 liters with mean pressure of 15, which is normal mean pulmonary pressures. And I've seen this woman in the office now for about the last 6 months, has no symptoms, residual symptoms from her pulmonary embolism, and has recovered well from her COVID infection. And I think that she is living as though this never happened to her, with the exception of continuing on anticoagulation. She went home, she had a prolonged hospital course because of her COVID infection, but from her pulmonary embolism story, there was no issue whatsoever. The next case is an extensive iliofemoral DVT. This is a gentleman, again, that presented at an outside hospital with heparin-induced thrombocytopenia with thrombosis. He had long, extensive bilateral DVTs. He had an IVC filter placed because of the worry of the thrombus burden, but he was continuing on anticoagulation, sent to our facility, diagnosed with HIT, initiated on argatroban. He had a small pulmonary embolism, and then had extensive lower extremity swelling with significant pain, about 4+ pitting edema. So the same thing with the patient in these situations are actually the patient is laying on their belly. We get access from their popliteal veins. And so what you're looking at actually is the left leg and the right side. So you're looking at the screen where the patient's laying on their belly. And what you're looking at here is the injection from the popliteal vein, and you'll see that the contrast kind of fades out right here. And this part's not as clear. I'm sorry about that. But you will see after aspiration, you'll start to see a lot more clear, and then a better picture over here where you can see the contrast in that location in the common femoral vein. So obviously it's cleared up the clot in the left lower extremity. And the same thing on the right femoral veins. You'll see large thrombus that's limiting your contrast injection and basically spiraling around. He has a dual common femoral, deep veins in the right side. And this is basically after the initial pass, where you can see now much more contrast filling and nice complete aspiration. And so similarly, this is reconstructed by our staff, both left side, right side. And so the patient's swelling was fully resolved, had 2 little stitches on the back of his knee, and that were removed on post-op day 1 and went home 2 days later. So just for the process. So obviously, not all clots are treated the same. Majority of patients will have small or submass or smaller DVTs or PEs. Those can be treated as we normally do with anticoagulation. These new tools and devices obviously are going to be used for selective cases. They do still need anticoagulation, but the biggest thing about it is long-term results. So you all know those patients that have had a DVT or PE, they still have residual symptoms. These are the things that are out there now that allow us to be much more aggressive and really affect the long-term quality of our patients' lives. And I think that speaks to the testament of what we have at the Heart Hospital, again, as with the new people and with our new tools and technology, we have these things that are available for patients that don't always know they need it. Questions? All right, thank you all for being here.